exposures. So your diet, your antibiotic exposures, early life exposures, changes in how you modify that will change the bacteria. And those bacteria will react to things that you put in. And in reaction to those will change how your gut health sort of modifies over time.
So if someone takes antibiotics, how will that change their microbiome? How permanent is it? And is it more of an effect if you're a baby, an infant versus an adult?
Yeah, our microbiome develops at a very young age, and that's when it's developing, it's the highest risk for changing permanently. So early life antibiotic exposures, absence of breastfeeding, travel or infections at a young age, those change your microbiome and they can be permanent. And those permanent changes have been associated with risks for developing inflammatory bowel disease or other immune-mediated disorders. So I think one thing that we've really started to focus on is early life interventions to really try to make sure that microbiome composition is as optimal as possible long-term. But we've also realized that, even later in life, things like ultra-processed foods, McDonald's, Burger King, Taco Bell, all these things can further reshape, how your microbiome responds to some of those things.
And anybody else could chime in. We're going to come back and talk a little bit about the microbiome. But the last one I want to ask before we move to somebody else, can probiotics change it to healthier bacteria? And is it permanent? And is there a future in probiotics for our health?
Yeah. There's a lot of interest in probiotics. The vast majority of probiotics don't actually get to the colon where they need to function. So I think there's less of a focus on probiotics and maybe more of a focus on trying to target specific bacteria to sort of modify or change them to treat disease.
Okay. Steve?
Along those lines, we talk about what are prebiotics, and prebiotics are foods that help healthy bacteria grow. And not to get into politics, but diversity, a broad spectrum of bacteria and fungi and viruses within our gut is really what helps to protect us against very specific bacteria you've heard of. Shigella, Salmonella, Campylobacter are very specific bacteria that can cause diseases, diarrhea, colitis, short term. But a healthy microbiome helps to protect and actually defend against these. So prebiotics, as we'll hear more about, are healthy foods. And these are foods that allow a more diverse group of bacteria and compounds to actually grow. Whereas, as Dr. Delay mentioned, ultra-processed foods are not natural. Our bodies didn't grow up with them. We actually evolved with bacteria, unless you live in Kansas. But through evolution, we have become very good vessels for bacteria. There's 1,000 times more bacteria living inside of us and on our skin than there are human cells. So if you crushed us, we'd be 1,000 times more bacteria than actually humans. And we've grown to live with this. But it's only after the past 100 years or so where our environment has become cleaner and probably too clean. We put chlorine in the water. We've got fluoride in the toothpaste. We're giving animals antibiotics. We're limiting the types of products that we're actually consuming now. There are 7 basic food groups. Where's Bethany could tell me we used to have a zillion types of corn. We now have 1 type of corn and along those lines. But that diversity of foods has really helped us. And as we have limited it, that's where we see immune diseases, not just ulcerative colitis and Crohn's, but rheumatoid arthritis, psoriasis, and many other chronic diseases are related to having a less diverse and a less adapted bacterial component within us.
So we'll come back to this. I'm going to get you next, John, but just to follow up real quick, are there other brain diseases that you think could be related to the microbiome? Alzheimer's, Parkinson's, depression, anxiety. Any thoughts about that?
Yeah, I mean, there's actually some really good science coming out now that the bacteria in your GI tract will modify how your body's nervous system reacts to different exposures. And it'll change your memory function, your responsiveness, Parkinson's. It'll change your risk for Alzheimer's. So I think it is truly your gut where everything starts. And your gut health really defines your risk for pretty much any disease at this point.
And I just want to add on to what Paramburst Dr. Delay said. There are 4 factors that have been associated with reducing the risk of developing inflammatory bowel disease that are very early in life. Vaginal deliveries instead of C-sections are healthier. Breastfeeding instead of formula feeding is healthier. Living with a furry pet, dogs in particular, is actually protective later in life. And then the 4th is avoiding antibiotics in young kids, as Dr. Delay's already said. And that applies not just to inflammatory bowel disease, but I will tell you it's going to apply to all immune diseases.
Okay, let's get Dr. Pandolfino involved here. Everyone's talking about artificial intelligence. Can you describe a little bit stuff with endoscopy?
Maybe the audience has a question about microbiome that they want.
Well, I thought we were gonna, but we could. I was gonna wait till the end to throw questions, but we're gonna come back. I have more questions on the
Please
microbiome.
interact with us. If you do have questions, raise your hand.
Yeah, but we are gonna save time for that at the end, and we're gonna come back. I still have way more microbiome questions for them. Is there anything pressing though, or can we wait a little bit? Okay. Dr. Pandolfino, we were talking about artificial intelligence. Can you tell us a little bit about endoscopic visualization, a little bit about the GI Genius, what we're doing, how artificial intelligence is impacting gastroenterology today?
Yeah, so one of the really nice aspects of AI in medicine is that it will improve diagnosis. And it can do that, whether it's getting a history from a patient, getting a blood test, or even looking at an image. And one of the things we've been working on here at Northwestern is developing AI tools that will actually look at your endoscopy, look at the recorded video, and then basically say whether or not it was a good colonoscopy or a good upper endoscopy, and then potentially look at it and actually make a diagnosis, pick out a polyp, or actually pick out a motility disorder like achalasia. And really what this is going to do is it's going to level the playing field so that everyone will have almost like an expert endoscopist doing their endoscopy. It's almost like having someone on your shoulder watching you do the exam and giving you that second pair of eyes so you don't miss anything. So you still need the doctor, you still need to perform the test, but now we're just going to have more accuracy, and that's what AI is going to deliver.
Can you describe to them what actually happens during a colonoscopy for a polyp?
Yeah, so there's GI Genius, which is a device that was made by Medtronic that we actually validated and actually looked at and showed that it actually improves colon cancer detection with a reduction in interval cancer rate. And we've also developed something called Colon Pro, which actually assesses the quality of a colonoscopy. So you know whether or not your endoscopist does a good quality exam. And we monitor that at Northwestern across the board. And I can tell you that if you get your colonoscopy at Northwestern Medicine, it's going to be high quality because we watch. But really what GI Genius does is the video is going, you're doing the endoscopy, and essentially a little box comes out, and in the Medtronic version it's green, and it literally just finds the polyp. So you could be going along and not see anything, but all of a sudden a box pops up, identifies a little spot, you look a little bit more closely, and then you notice that that might have been a polyp that you would have missed. So you do the biopsy. So it really is a little bit of redundancy, but really important redundancy because you're not going to miss stuff. So, we have this now across every endoscopy suite in the entire 11 hospital system because we saw that it worked. And when we showed our CEO that we could reduce interval colon cancer by up to 30%, he was like, how could we not have this at every endoscopy lab in Northwestern Medicine?
And just to explain, when he says interval colon cancer, that means the time between when you had it and when you were told to have your next one. Hopefully you don't get anything in between. That's the interval. So Dr. Hanauer, everyone talks about, I get nervous, I get upset, my gut gets disturbed. Can you tell us a little bit about the mind-gut interaction?
So it's really quite intuitive to us. And I go to simple examples. When you scare an animal, they defecate. We say we're scared shitless. Right? Performers go on stage and they get butterflies. We know that I say that our gut is our mirror to the world. When we get upset, our guts get upset. On the other hand, when we calm ourselves down, and what's the first thing you say to a baby who's crying or a little kid that's crying? What do you tell them? Tell them, take a deep breath. And actually, we're learning, and our behavioral therapists who can talk more about this in a little bit, that we have means that we can actually get our nervous system to calm down and actually reduce this feedback between the gut and the brain. And we do this all the time. When we go to sleep, you don't hear the train going by, but if a baby cries, you actually hear that. Our brain is able to filter out the different messages for us. And if we learn how to utilize that to our advantage, we can control many of our gut symptoms.
Is there someone from our crew that could show what diaphragmatic breathing is to help relax?
A few people they can.
So a good you guys want to demonstrate for us?
Come on up.
Come on, Kate around.
Need a chair?
Do it together. It starts out, how many of you in the audience do yoga? Raise your hands, have done yoga. What's the first thing you start with? Deep breathing, ujjayi breathing. That's what diaphragmatic breathing is. It's a slow, controlled inhalation and a equally slow, controlled exhalation. Is that okay?
Good job. That's why we got the experts.
We want the experts, stand up and show us all.
Comfortable demonstration. We can do it. We can do it. Yeah.
Yes, good practice.
Do you want to practice together? Let's do it. So start off by putting one hand here and then one hand just above your belly button. Okay. And to do a diaphragm breath, you want to inhale and inflate the belly like a balloon. Breathe in through your nose. Breathing in, yeah. Extend the belly like a balloon. Out through your mouth. So you can really slow down the exhale. And keep this part of your body still.
I want to put everyone to sleep though.
Okay.
You will notice that your heart rate actually goes down. And that's part of the process of this connection.
Doing this breathing helps to stimulate the parasympathetic nervous system response, which is the rest and digest response. So it is very helpful for digestion and relaxation. So we generally teach patients that almost the first visit we see them to start practicing it twice a day, starting with 5 minutes in the morning, 5 minutes in the evening, and then you build up a familiarity with the technique, and then you can apply it all day long. It's a very portable skill.
Who would you send to them to be
Let me give you another
evaluated?
example. How many of you guys are the men are football fans? And you see, how many watched JJ McCarthy from Michigan last year? What does he do before,
did.
or Justin Fields before every game? They sit under the goalpost and they do deep breathing meditation exercises to calm themselves before every football game.
Yeah, so actually, in addition to what we just heard, for reflux disease, diaphragmatic breathing is actually very important because it actually literally converts the physiology and the mechanics of your breathing to actually prevent reflux. Because as you relax your stomach, that pressure gradient is reduced. So one of the things that we do in all of our reflux patients is actually we ask them to look at our diaphragmatic breathing videos that we have already produced ourselves and actually have them do that. And in particular, people have significant regurgitation or something called rumination syndrome. We can completely cure that with diaphragmatic breathing. There are randomized controlled trials supporting that.
So the last question on this topic, when someone does feel there's a lot of stress and tension and there's no disease that you've identified, is there a role for gut-directed hypnotherapy?
I think the shortest answer is it depends, right? So some people would be really good candidates for it. Oh, I was making a noise, but okay. It depends. So some people would be really good candidates for gut-directed hypnosis, but we would usually meet with them and talk to them about other life experiences that could affect how well it would work. But it could. So someone who has a lot of chronic abdominal pain, someone who has IBS, for example, overlapping inflammatory bowel disease or IBS in general, people with reflux and esophageal hypersensitivity could all potentially be candidates, but we would do an evaluation to see what might make you not the best candidate. A significant trauma history sometimes can impact one's ability to benefit from hypnotherapy. But there's really good evidence for gut-directed hypnosis for a lot of our patients.
Yeah, and I will tell you, it is a little difficult though, when you're seeing a patient in your clinic and they come to you for a GI complaint, and then you start talking to them about sending them to one of our psychologists, our gastropsychologists, they automatically think this is all in your head and you're crazy. And I think that we've learned, and one of the things that we've done here at Northwestern for the last 15 years has really been promoting this idea that we do not think that you're crazy and that this is something that we can modify. And you can give very simple examples, like you're putting your glasses on, you feel your glasses, but in a couple of minutes, you're not going to feel your glasses. And how does your brain do that? How does it shut stuff off? It diverts its attention. Like pickpockets, how do they pickpocket? And I don't want to say I'm not a pickpocket, but they tap you and then they go into your pocket. They distract you, right? Because you can't do two things at once. And when you explain that to patients, that really what some of these therapies like hypnosis is doing is really diverting your attention away, and that will improve your symptoms. And all symptoms are in your head. If you didn't have a brain, you wouldn't feel anything. And it really is just modulating that. And I think that's a very important thing that we're very good at describing and putting people on a tee for our behavioral specialists who are doing this. Because if we don't set the stage for that, there's always this kind of like stigma with it. And I think we've done a very good job of getting around that now.
And I believe you've shown that people who use this reduce their medication use, they reduce their visits to the doctors, they reduce their visits to emergency room.
Yeah, we actually have a randomized controlled trial, NIH funded right now, that is actually looking at a behavioral therapy versus our standard of care kind of lifestyle modification. We've already shown in an open trial that it works very effectively for people with esophageal problems. So our hope is that this randomized controlled trial will even make this even more mainstream.
And clearly, this is one of the prides we have at the Digestive Health Center is that they really look at patients in a way that not everything requires a test and a medication, but you think of them really as the total person. And I think we're very advanced in that role. And that's why I wanted to emphasize all this diaphragm breathing and hypnotherapy and all the other stuff that our teams can do. So coming back to you, Dr. Delai, I know your area is inflammatory bowel. Is there anything that we're doing with the microbiome to treat people with Crohn's and ulcerative colitis? Is there a role for fecal transplants in treating it? Can you give us an update on that?
Yeah, I mean, I think there's probably several different things that both can be done and that we're doing specifically. One thing that our lab has done is we have discovered new bacteria targets that we can actually treat with medications that should become therapeutic sort of drugs for patients to actually start using in the next 5 to 10 years. The other big thing that we want to do is we want to start shifting away from this assumption that people's bacteria or their gut composition and dysbiosis is not a major contributor to actually measuring some of these things. Like I said, your bacteria in your body are a function of your lived exposures. And if we can measure that in some way or use your stool to actually understand what's happened to you throughout your life, we might be able to modify specific aspects. So what we're working on in the lab right now is a way for somebody to actually just drop off a single stool sample, and we can tell you exactly what you ate in the last 7 days, whether you got antibiotics, what kind of antibiotics you got, and how that changed your microbiome and your immune system. And some of those kind of things are where I think we're shifting to, where we can actually use your microbiome to both monitor your body and your disease to try to find a balance between the two.
Anything else,
Just
Steve?
asking, what is dysbiosis?
Yeah, so just like Steve, Dr. Hanauer talked about diversity, dysbiosis is a lack of diversity. So over time, you get exposed to certain things that change your microbiome so that you have certain bacteria that become very dominant. So imagine you have 1,000 different bacteria in your gut. You eat something, they're all competing for the same food. At some point, some of them start to win out. Some of them may also win out if they survive the antibiotics that you're exposed to. Some of those bacteria may also win out if they survive the infection that you endured when you're traveling abroad. So that dysbiosis is basically just the bacteria that survive your lived exposures. And if it's the wrong bacteria that survive, they will cause inflammation. And because they're the only ones there, they'll continue to cause it until you change what's around them by either transplanting new stool in there to change the bacteria or specifically trying to target, starving them or killing them.
How many of you have seen the movie Blazing Saddles? Do you remember the campfire scene with the men sitting around the campfire eating the cans of beans, and intermittently one gets up and sits down? That's what our microbiome does. It breaks down many of the foods that we can't. And one of the products, several of the products are gas and different types of gas, depending on what different sugars people are consuming.
When they talk about Crohn's and ulcerative colitis having a genetic component, could some of the genetic component be your inherited microbiome?
So it's interesting. There's been this, big push for the last 20 years or so about genetics in Crohn's and ulcerative colitis. When you really distill down to it, they actually have a lot of shared genetics behind them. And what we're realizing is that the genetics is not a function of disease. It's actually just telling you how your body is going to respond to the bacteria. So what a lot of people have started to learn is that genetics is just how your body's going to react to specific bacteria in your gut. And I think the microbiome has now been demonstrated to actually shape your genetic changes over time. So I think it's a combination of the two together that really drive what separates Crohn's from ulcerative colitis.
You don't really inherit a microbiome, you acquire it. Babies are born in the womb are sterile. When they pass out of the birth canal, they're already getting bacteria from the mother, from the birth canal. When they're breastfeeding, they're getting bacteria from the skin around the breast from the mother. And that's their first exposure. And that's how the microbiome starts to build from that. So you can imagine why a cesarean section, which is very sterile, and then formula feeding, which is not mother's milk, prevent the baby from getting some of the natural bacteria in the microbiome from the mother.
And it's a very dynamic process. So if you move to another country, within 3 to 4 months, your entire microbiome changes. And you adapt to having a microbiome that's more consistent with the people that live there. And if you move back, it changes back within about 6 months. So it's a very dynamic process that you can modify and is modified by what you're doing.
Good. So, Dr. Pandolfino, we just got a gift to name the esophageal center, the Kenneth Griffin Esophageal Center. And one of the things that really intrigued him was all the stuff you were doing with creating with mathematics and engineers a virtual esophagus. Can you describe what you're doing? I mean, it's revolutionary. You're probably first in the kind. What is this virtual esophagus that you're developing, and how can it be used to advance medicine?
So I guess high-level hedge funds and financial strategy is in line with what we do in medicine in terms of AI and using predictive modeling to diagnose patients and personalize their therapy. And really one of the things that Mr. Griffin was intrigued about was the fact that we were trying to use mathematics to create an in silico organ, meaning an organ that looks like the esophagus, for instance, that's living on a server. It looks kind of like a cartoon, and we can take information that we develop from high-level testing, physiologic testing, feed it into that model, and then it becomes a mirror or a twin, a virtual twin of that patient's esophagus. And then we can do surgery. We can modify the esophagus based on what we think medicines would do to the esophagus and see how that affects the function. And right now we have a program, we call it ESO Einstein, where we're going to take all of the questionnaire data, all the psychometric data that we acquire from patients, input that into a model that works with an artificial intelligence endoscopy video. So it'll look at the video, figure out what disease may be at play, and then use something called the flip device that'll actually put the mechanics of the esophagus and then develop that virtual twin. And thereby, we won't have to do clinical trials in the esophagus anymore. We can actually simulate surgeries in the esophagus. We can simulate medication, dilations like endoscopic procedures, and see how they work. So this is really the new frontier. And right now, we are the only center that has actually developed a virtual organ in the GI tract and have validated it in one of those models where we could predict a surgical complication with a specific operation.
You develop something so reflux is a common problem, heartburn, reflux. They can't all get in to see a doctor very quickly. You developed something called the chatbot. Can you explain it and tell us how it's used?
Developed a chatbot because then I wouldn't be sitting here. I'd be on an island somewhere.
Okay.
But
He actually invented the internet. That's
Yeah.
but
I always thought you were great, but now
yeah. Well, I mean, one of the things, everyone struggles with some of these common problems, and you can't get in to see the doctor. You have a 3-6 month wait. So one of the things that we decided to do was just take a chatbot and create something called a GERD-bot. And essentially, it's a very simple machine learning tree algorithm where you answer questions, and depending on what your answer is, you just get funneled to a different level. And then what we were able to do with that is actually increase the access of our patients. So instead of waiting 3 to 6 months, you literally do the GERD-bot, and then you'll be put with a APP, an advanced practice provider, who will then actually start you on your therapy within 72 hours. And you can get scheduled for an endoscopy, and it'll look where you live. And if you live in the western suburbs, you'll get your endoscopy in the western suburbs, so you don't have to travel downtown. So it's really providing optimal care where you live in a very streamlined fashion using a chatbot, which everybody probably uses every day. You go to buy something online, you make travel reservations. Those are chatbots. We just leveraged it to use it in a very simple algorithm for gastroesophageal reflux disease.
So everyone talks about the great things of artificial intelligence. What is some of the risk factors of using it in GI?
Yeah, I mean, the main risk factors is garbage in, garbage out. So that I would say is the most important thing, because if you train a model and it predicts something, but it's based off of bad data or bad input, then it's going to give you the wrong answer. So really, one of the big things you have to do is be very careful with your data and protecting that data and cleaning that data. So that's certainly one of the big risks. The other thing is that there's some bias in AI. AI actually picks up things that can be related to bias and translate that. So it can propagate that. So when you're actually designing these particular tools, you have to be careful that your data, once again, is completely de-identified and you can stratify it and take away some of these things that may drive bias. So there are certainly that. And then, of course, whenever you're dealing with big data, there's always the issue of identifying de-identified data. Now, we've become a lot more sophisticated with that. And the risks of that are less and less with all the firewalls and all of the algorithms that we use to decode and encode your data. So that's less and less of a risk, but I think that's one of the issues. I think people always worry that we're going to be replaced. Our doctor is going to be replaced. And I don't think we're going to see that doctors are replaced. We're just going to be able to do things in a much different way at a higher level. You know, programming is probably going to be replaced by ChatGPT. You don't have to learn how to program anymore. You can just ask ChatGPT to do that. Well, similarly, I mean, you're still going to have to ask the right questions. You're going to have to make sure that the patient is inputting the right data. And then when they get that answer, they understand it. They understand how to use that information and for you to put them in the right hands. So I think we're in a good spot. The other thing is, if you're an endoscopist, you're fine for at least another 30, 40 years because autonomous AI colonoscopy is not going to be something that's going to be available. So you're still going to need your NM gastroenterologist for your colonoscopy.
Okay.
When we do the colonoscopies with GI Genius, as Dr. Pandolfino said, we get a little green box that outlines what the Genius thinks is a polyp. Shri, what is it? 80% are not really polyps. We have to look at it different ways to make sure. They're often overly sensitive to make us take a deeper look at it. But they're not always specific for polyps.
And then, you know, AI has even reached into what Dr. Dulai does. I mean, if you look at it, the advances that have occurred really in genomics and the microbiome have really been predicated on the mathematical exploration of large gene sets and these huge numbers of bacteria. And if you really didn't have these machine learning mathematical tools, it would be almost impossible to interpret all of that data that we're getting on a daily basis in his lab.
Yeah, I mean, the AI tools that are used now to design drugs, to figure out what kind of drugs will work, to screen 10 to 20,000 sort of different compounds. It's all AI work. I think one of the biggest concerns, though, is, you know, how do you know if it's right? And I think that validity to some of it is something that people are working through, but it is permeating everything that we do now.
Okay, so we'll go for another 5 minutes and then open it up. Just a couple things that people wanted to talk about. In colon cancer screening, we all know about the colonoscopy, but could our panel talk a little bit about the pros and cons of the newer blood tests, the Cologuard? What are some of the advantages and disadvantages versus just doing a colonoscopy?
Well, I mean,
Everybody should get a colonoscopy.
yeah. Well, you know, I mean, I do think that the blood tests and Cologuard are things that would expand access, right? So if you don't get any screening, that's the worst screening, right? So if you don't do anything, that person's going to be at risk. So the fact that we're seeing blood tests and Cologuard and stool tests is very important because we want everyone to be screened. Now, unfortunately, the blood test is really not that accurate. It still misses a lot. It only finds you when you're pretty far along. So you have some degree of sense of comfort that you don't have a cancer, but it doesn't really stratify you. Regardless, you know, colonoscopy is still the gold standard. It's the most accurate. But, you know, we are constantly looking for opportunities to expand access, make sure that everybody gets screened. And then only the people who really need a colonoscopy, who need a polyp taken out or an assessment, you know, because they have inflammation, they'll get their colonoscopy. So we're not really worried about our business. The number of colonoscopies is probably going to stay the same. It's just that we're going to be more precise. It'll be more personalized. So when we do it, we're going to be going in to take out a polyp. We're going to go in to diagnose that cancer so that you can get therapy. And I think that's really where the blood test and the Cologuard are going to be helpful, but really not a replacement for the accuracy of colonoscopy.
And let me say it a little bit differently. Cologuard and the blood tests detect cancer. Colonoscopy can prevent cancer by identifying these small lesions that would grow into cancers over a number of years. And when we remove these little polyps, it prevents them from growing into cancer. Cologuard will detect a cancer, but or a larger polyp. Same with the blood test, but they won't prevent it.
Yeah, we actually just on the Cologuard thing, we just did a very small study really quickly to show that if you have a positive Cologuard, the GI Genius actually improves detection rates of those polyps. So you can imagine if you have a positive Cologuard and they don't find anything, you're really nervous. But if you have a positive Cologuard, the doctor doesn't find anything and GI Genius doesn't find anything, then you feel a lot more comfortable that you probably don't have anything that was a false positive. So really important to utilize all of these things together to get to the right answer.
Yeah, I mean, I agree with Dr. Pandolfino and Dr. Hanauer. I think colonoscopy remains the gold standard, and Cologuard and the blood test to help expand access. We also have to remember that Cologuard and the blood test are in their infancy. So, but the technology is extremely promising. And I think with future iterations, there's potential for those to become progressively better at detecting early polyps. And we are helping those companies do that here at Northwestern and expanding it into sort of screening for IBD patients and other populations that haven't been studied yet.
Okay, I'm going to make one pivot before we open it to questions. People have been asking, pancreatic cancer is rapidly rising. Some have predicted that it'll be the #2 cancer by 2030. And yet screening for that has been very poor. Dr. Comandori, I know this is one of your expertise areas. Why don't you share some of your thoughts about what can we do with this? What kind of screening can be done, if anything? What could someone do if they were worried or had a family history?
Yeah, this is a lot. I think the first thing is to understand the layers of risk. And I think we all fear pancreatic cancer, but there are a lot more risks that we understand. And some of this is very genetically driven and maybe microbiome driven. But there are patients that we see quite frequently and more recently understand that risk better. So patients, for example, who have a strong family history of breast cancer and BRCA, which is one of those mutations you've probably heard of. There are a laundry list of this, and it's a cascade starting at somebody who has, hey, I had an uncle with pancreatic cancer, all the way through very much higher risk mutations and sort of genetic syndromes. And for those, we've sort of identified a pathway, not only with high-end imaging, endoscopic imaging, but also blood tests that can actually identify that mutation and push things forward to prevent that. We've also seen, if you're fortunate to have a CT scan or an MRI, it's more likely than not to find a cyst in your pancreas nowadays. And so that's also another route that we've used because, it's kind of like the conversion of analog TV to what we have now in 5K and 4K, and we're seeing things that were always there. So with that comes a lot of unnecessary workups too. So we want to be thoughtful where on this risk platform that you lie. Probably the elephant in the room is, hey, can I just get the blood test? Or can I just go for that MRI that's on Facebook, which is, we see this now, which is the whole body sort of screening test. I can tell you, and I'm sure all of us have seen those MRIs, which are not very effective, provide many patients with tremendous anxiety, and then they need to have diaphragmatic breathing because they're worried about something that's a false positive. So I think, really working, and this is something that we are evolving right now in pancreatic cancer, is how effective the blood tests are not sensitive and specific enough to just say, hey, everyone should get it. But there may come a time as it sort of gets combined with all of these things you're hearing about. But that being said, if there are risk factors that are within the family and some of them go well beyond, or if you just don't know, we're here to help you kind of answer those questions. There are pathways and algorithms to make sure those at any level of risk don't develop the deadly disease.
All right, so why don't we open it up for some questions? Does anyone in the crowd have something they wanted to ask.
How does one access the GERD bot? Is that like open to anybody on the website?
Yeah, I mean, if you go and you Google NM-GERD, you can get access to it and it'll go through the questions. But I mean, how we envision it mostly working is that your primary care doctor makes a referral and gives you the link, and this can be done through Epic, to go to the GERD bot, and then you go on, you register, and most time you're already registered at through Northwestern, and then you just answer the questions. So it's pretty straightforward, but it isn't just the GERD bot alone. You know, we have these really great nurse practitioners and physician assistants who are really driving a lot of this. It just makes their lives easier so that they can get all of the information very quickly and make a decision, get the patient to the right provider, because sometimes it's a surgeon, sometimes it's a dietitian, sometimes it's a psychologist. So it's really important that you don't see a surgeon if you've never even tried some lifestyle modification. So it really makes it more precise and easier for the patient.
The briefing video, is that available online?
Yes, it is. And
Maybe after the session, you'll, at the information session, you can get it directly.
They're going to be having tables set up and you can individually come and talk to them too.
Dr. Pandit also printed out some great handouts too. So on the breathing and everything. I'm here. Yep.
Thank you. Thank you for this great panel. I have two questions, but before I ask my question, I want to say a really big thank you to the team. I was among the first patient 10 years ago with Dr. Benofino. I was really miserable at that time. I had many symptoms. It ended up being diagnosed at EOE, eosinophilic esophagitis. And Dr. Penofino, Bethany, Dr. Gonzalez really helped me through all the therapy, the medication at first, and then eventually the elimination diet. Through these 10 years, I went and I reached remission in December, so I'm very pleased with that. But one of my question has to do with the endoscopy and the process of doing endoscopy. I think I had 11 endoscopy over that period. Every time it's costly, it's complex, and I'm wondering if there's new methods to simplify, to make it cheaper and faster and so on and so forth. So that's the first question.
probably divert to Dr. Comanduri and Dr. Gonzalez because they're both doing some research and developing tools that are hopefully going to improve that. So maybe you can talk about the string test and then.
So as was just pointed out, one of the things and the challenges with dietary therapy for eosinophilic esophagitis, and eosinophilic esophagitis, for those in the room that don't know, it is a food allergy driven condition of the esophagus, which causes a lot of scarring and difficulty swallowing. And when we go through these dietary trials, we take out foods to try and get people in remission and then add foods back with endoscopies in between to try and understand that food trigger.
How do you know which foods to take out?
So there's a lot of data behind this, and the most common food triggers in eosinophilic esophagitis are known as the big 6 or 8, which is milk and wheat are the top 2. Soy and egg are the next 2 likely, and seafood and nuts are the least likely culprits in EOE, and that's very similar to food allergies in general. So as was pointed out, doing endoscopies is very costly. It's difficult. You're taking time off of work. So there's been a lot of push from patient advocacy groups to really find these minimally invasive tools. One in particular, and I'll let Dr. Comanduri follow up with some of the other ones, but one in particular that's been used for EOE is something called the esophageal string test. And Northwestern was actually part of the initial research to developed this test together with Colorado Children's and UIC. It's a little capsule with a string housed inside it. Patients swallow that string, swallow the capsule. The string sits in your esophagus for an hour. It gets pulled out, put in a little test tube, and it goes on to the lab, and they can give us a score, an EOE score, to say you're active or you're not active. And this was recently FDA approved. So this is something that we are trying and will be bringing to Northwestern soon, and is a perfect example of when you're doing food trials and trying to assess this inflammation using something like that instead of having to go through that endoscopy. There's also been the cytosponge, which is a little sponge-like device in a capsule that does a similar thing. There hasn't been as much interest in that in the EOE space. And also transnasal endoscopy has been looked at in the EOE space, but I'm going to let Dr. Commodore talk a little bit more about that.
Yeah, I think that was probably a well-planted question for us, because I think what you're detecting from the experts up here is the shift is towards prevention, right? And we haven't spent a lot of time on cancer, but we talked about colon cancer, pancreatic cancer, and even esophageal cancer, and prevention driven by innovation. And that's what you're going to see happen. And a lot of that is early assessment with exactly the experience you underwent to avoid that. And some of the things we're looking at is using the transnasal endoscopy and little capsules that you swallow on a string that you can pull back out and sample your esophagus, and with a high degree of accuracy, tell you whether you have Barrett's esophagus or not. You know, why is it important? For example, in esophageal cancer, the vast majority of people don't have symptoms of heartburn, but they have bad reflux. And the first time they come to us is with a cancer, and that's deadly, as you know. So all these technologies and these innovations are things we are pioneering, not only to foster preventive strategies in cancer of the GI tract, but also to address exactly what you talked about, which is not everyone needs to have 11 sedated endoscopies, and the cost and the resource utilization, when we can potentially do a point of care assessment, even at the office, you know, without going to the lab. That's much more cost effective.
Very pleased to have reached a revision stage. I feel really good about it. Now, how long does the revision stage last, or is it possible to be recurring? And symptoms can be either.
We might as well hand it back to Dr. Gonzalez.
All right, this is my favorite topic. I could talk about this all night long, but I won't. No, when we're talking about EOE, it's very important to get into remission, as is stated, meaning decrease that inflammation, however way you can do that. If it's a food elimination diet and finding your food triggers, it's avoiding that food moving forward. If it's using different medications, whether or not it's swallowed topical corticosteroids, proton pump inhibitors, or even new biologic therapies, it is important to continue that therapy. So continue maintenance therapy. There's lots of evidence that suggests if you stop that therapy, that disease will recur. We talk about it being similar to asthma. People with EOE need to be on some type of therapy to keep their esophagus open, similar to patients who may need to take an inhaler every day to keep their lungs open. So maintenance, once you're in remission, it typically persists if you stay on therapy. If you don't, it can recur within weeks to months.
One or two more, and then we'll take a break. Everyone will be available to talk.
Where there's the microbiome center.
Yeah, where should you move? Yeah. So it's not surprisingly to rural areas that have very limited access to fast food. So, you know, one of the things that we're starting to see is that internationally, there's a growing number of patients being diagnosed with autoimmune conditions, inflammatory bowel disease, eosinophilic esophagitis. And with that, there's an assumption that that's because of the westernization of their diets. And so it's not just a matter of sort of where you move, it's sort of a function of what you do when you get there. And so I think that's a big part of it. The other thing that's really interesting is just the act of traveling, regardless of where you go, will actually dramatically change your microbiome. So how many people here have taken a long haul flight, a flight for more than 6 hours? How many of you just don't feel right afterwards when you get there, right? You're constipated or you're just not feeling right. Well, your body's system is developed to adapt to changes in pressure, changes in oxygen. Those planes are not pressurized. You change sea level, you change your height, you go high altitude. Your body tries to adapt. And with your body's adaptation, things that happen are the bacteria in your gut get exposed to different sort of amounts of oxygen, different tensions, and they start adapting and they start changing how they react. And that whole cascade really drives how you feel when you travel, regardless of where you travel or how you travel. So I think the whole concept and the whole process is really important. And that's where Dr. Hanauer was getting at the concept of prebiotics. Big push to start thinking about certain diets when you're traveling, when you take a long haul flight, maybe intermittent fasting so that you don't actually experience quite as much or you don't sort of have as much of an issue. So there's a lot of research going into how to modify or do that on a daily basis. But there's a huge impact from very simple things that you do.
And one of our younger investigators, Dr. Keith Suma, is very interested in day and night. Our microbiome is not even stable throughout. So Keith, why don't you tell us a little bit of what you've learned?
So I am really interested in how our body adapts to the environmental cycle of night and day. And our bodies have a clock. That clock helps us know when the sun is going to rise, when it's going to set. That helps our body set our sleep-wake cycle. It helps set up our metabolism so that we're ready to digest food when we're eating, and that our body can rest and recover at times when we're not eating. And, what we've studied and learned is that if you disrupt this sleep-wake cycle or the circadian rhythm, you can precipitate changes to the gut bacteria, which can predispose to inflammation and to basically poor healing of the gut in response to challenges that can lead to colitis and the development of inflammation. So there are a lot of these factors that all kind of work together, and the gut is kind of at the epicenter of all of this.
All right, so I think we're really at time. Everyone's going to be here. Our illustrious panel, our if you want to learn about diaphragmatic breathing or hypnotherapy, they're here. So let's take a break. Thank you all for coming here. We really enjoyed it.
No, I'm just gonna put these in here and I'm gonna turn off the Zoom. You're welcome. You're welcome. I did not steal. Thank you so much. Thank you. Okay, so let's see here. Oops.
Yeah, no. So it's helping me out. So our clinic will probably open back up. Thanks again, Michael. Bye. I know, well, it was a risk, but well, I mean, but recently, I wasn't like, I wasn't, I'm telling you, I mean, I was nervous, because it's not easy out there. It wasn't easy. Like,